Good afternoon and good evening to everyone who is joining us on this webinar today. My name is Dr. Harpreet Sood. I'm a primary care doctor in London, UK, working in the NHS, a trustee of the South Asian Health Foundation, and also a board member at Health Education England. So together with our partners, we have put together a series of webinars to use as an opportunity to learn, share experiences and knowledges amongst healthcare professionals from the UK, NHS, with India and beyond. We have had an overwhelming response from colleagues in India with the current situation, who have provided us with many areas of interest and topics that they would want covered. And in response to that, we have organized a series of webinars to help with the experiences and knowledge from colleagues in the UK. These webinars will provide a clinical view from NHS experts who will share their experiences and insights on how they best managed the COVID-19 pandemic, in particular the second wave. And the webinars will not be discussing policy or politics. Today's topic is going to be on COVID oximetry at home and looking at how remote management was developed in the NHS. This has been a great success in the UK, and I'm joined by an esteemed group of panel members from both the UK and India. I would also like to thank all our partners who have rapidly made this happen for colleagues, and also for colleagues in India who are joining us during this stressful time. Now, given where we are with the situation, I think it's important to start with the context of India and India's healthcare system. This is usually a mixture of both private and public provision, with a large proportion of self-pay. And under India's decentralized approach to healthcare delivery, the states are usually responsible for organizing healthcare services. Now, combine this with a limited primary care infrastructure and staff shortages with shortages of supplies at government facilities, many households usually end up seeking care from private providers and pay out of pocket. And for low-income people, the government has recently launched the tax finance National Health Protection Scheme, the AHSN Network. Now, even though we have organizational and cultural differences, there are still many things we can learn and share with one another. But more importantly, this is an opportunity to provide reassurance and hope, and also get that experience from the UK colleagues. The format of today's session will involve three speakers. We'll have the first view from Dr. Atul Patel from India. Then we will talk about the COVID oximetry at home program. And then Dr. Smith will give us a view of the clinical COVID assessment service. We will then follow this by a question and answer session where we'll open up for discussion. So without further ado, let me open up with our first speaker, Dr. Atul Patel. And can I request each panel member to briefly introduce themselves before their presentations? Dr. Patel.
Hi, good evening. I'm Dr. Atul Patel. I'm an internist and practicing adult infectious disease in Ahmedabad. Thank you for inviting me, and good evening to all. So I'm going to speak on COVID-19 remote monitoring and management at home. Yeah. So the most important thing that we should understand that nearly 80% of the COVID patients, they are going to experience the milder symptoms, and they are going to have a spontaneous recovery. And that's the reason that we recommend home isolation and home management for most of the patients to begin with, right? But the current situation in India, because of the large surge in the COVID-19 patients during this second wave, the real situation here is that, like, we do not have the hospital beds available. We do not have the ICU beds. And the most important reasons for this, the hospital beds and the ICU beds are full. The important reason is that many of the asymptomatic patients or the patient with the milder symptoms, those who do not require a hospitalization, they are occupying these hospital beds because of their fear. So I think fear is very important current problem in India. this fear amongst the patients as well as among the doctors also. Like the doctors also do not want to take any chance that, look, my patient is having COVID-19 diagnosis, he's having cough, he's having fever. So let me admit and let me monitor into the hospitals. And that's why the beds are occupied. But we know that like 80% of the patients, they do have a spontaneous recovery. And how we should manage these patients at home. Can I have next slide, please? The most important thing that when we recommend the home isolation or the home management to COVID-19 patients, we need to find out, are my patient is having any important poor prognostic markers or the risk factors for disease progressions? And now after 1 year of COVID-19 outbreak, we know that there are few very important poor prognostic markers. Those are the demographic and some of them are laboratory markers. So we know the comorbidities like diabetes, hypertension, the obesity, all are very important, the markers for poor outcome in COVID-19 infected patients. So from the patient's demography, the patient's the medical history, we know that this patient is likely to have a disease progressions. Apart from this, like we do have few laboratory markers and which are very cheap and easily been performed. The one important marker would be the simple blood count or the complete blood counts, where you have to look at the neutrophil lymphocyte ratio. So at the baseline, when somebody has a diagnosis of COVID-19, we have to assess for the presence or absence of poor prognostic markers, especially the laboratory markers also. So if somebody is having a neutrophil lymphocyte ratio of more than 3.13, then we know that these are the patients who has a poor prognosis. They do have increased risk of disease progressions and require hospitalization because of the complications. Apart from this, age is another important, very important, the poor prognostic markers. And in this study, you see that like when the age increases from 51 years, you see the orange bars, right? The size of orange bar increases. These are all the patients who died because of the COVID-19. So it's very clear that once the age increases, the chances of poor outcome increases. So age is another very important. And that another important laboratory marker that we can do very easily would be C-reactive protein. So if somebody is having inflammation at the baseline, then we should be very careful. So when we recommend home isolation to a patient who is having a COVID-19 diagnosis, at a baseline, like we need to identify and chart out what are the important risk factors for this gentleman or the female patients where we expect a rapid worsening or the clinical deterioration. So if somebody is having any abnormal or the many risk factors, then probably we may give more attention and to find out the risk of progressions. Next slide, please. So these simple basic demography and the laboratory parameters are extremely important. So whenever we recommend home isolation, we try to find out this, the important prognostic markers. And when we ask them for a home isolation, the most important thing that in India, especially this is very true in current the season, the hydration is very important and which is most neglected component. And many of these patients, they are running high-grade fever, 101, 102 degree Fahrenheit. They are not having adequate oral intakes. They may have some abdominal symptoms like some loose motions, or patients may have some nausea. And because of all these things like high ambient temperature, running fever, some GI symptoms, all these conditions leads to the dehydration. And these patients, they have variety of symptoms because of dehydration. So I think we should ensure, we should educate them that they should have good hydrations or the adequate hydration. At least what I recommend to my patients is that at least they should have 50 ml per kilogram per day of hydration. So it could be simple plain water or buttermilk or lemon juice or whatever fluid that they like. Right, so adequate hydration is very important component, and probably it will take care of so many symptoms that most of these COVID patients in a home isolation, they are experiencing like body pain, weakness, some dizziness because of the poor the circulating blood volume. So variety of symptoms patients can have, and this can be taken care by simple hydration. So I think we should give more importance to the hydration at home. The another things that I try to teach to most of my patients, especially those who has the risk of disease progressions, I'll explain them how to have a proning. If proning is not possible, then semi-prone position. So both these things, I think we should explain to all the patients, because those patients who has a risk of disease progressions, having the lung inflammations, parenchymal GGOs leading to the hypoxemia, I think these prone positions, when they are good, like they are having only fever, body pain, or some constitutional symptoms, they are able to understand like how the prone positions, I mean, they can go for prone positions. And we should also explain the importance of prone positioning in alleviating the hypoxemia. So I think this is the second thing that I explain to all the patients, apart from hydration, would be prone positioning. The third thing that, I mean, we should give, especially in India, like the steroid overuse or the misuse is very commonly seen in patient who has a COVID-19 diagnosis. So most of these COVID-19 patients, even during the first week of their illness, like in day second, day third, when they presented to the clinicians, invariably like they are prescribed steroids during the first week. I think this is detrimental, and we should avoid unnecessary steroids, systemic steroids in COVID-19 patients. And not only steroids, like I'll recommend, like we should avoid all unnecessary pharmacological intervention. In India, like, I mean, most of these patients, they are receiving doxycycline, azithromycin, ivermectin, and the cocktails of vitamins like zinc supplementations and vitamin D, calcium, and etc., etc. So I think we should avoid unnecessary pharmacological intervention, ask the patient to have good hydration, good food, adequate rest, prone positioning, and avoid steroids. Like this is extremely important, because giving the steroids during the first week of illness is going to damage the patient's innate immune system. And the innate immune system is extremely important in containing the replicating virus during the first week time. So by damaging this, like we are probably giving more chance of replicating virus into the patient's body system, which produces the subsequent more the damage to the lungs and the other organs. The fourth thing is very important, that is home pulse oximetry. So today's entire session will be on the pulse oximetry. So I'm not going to take much on the pulse oximetry, but let me tell you that the trend of pulse oximetry is extremely important rather than a single reading, right? So I need to explain patient that, look, one abnormal reading, please do not afraid. Just look at the trend. Like if you are maintaining 97, 98, and if single day reading comes 92, and then again, like after, I mean, 10, 15 minutes, again, if it is 96, 97, then do not worry about that, because there are so many the conditions which can lead to the erroneous, the pulse oximetry results that we are going to discuss in the entire session. So I'm not going to discuss that. But the important thing is that when somebody is keeping more than 94 pulse oximetry saturation, then we expect that their PaO2 would be normal, so 80 to 100 the millimeter of mercury. But when the SpO2 falls less than 94, then this is hypoxia. So we should alert our patient that if they have the series of the pulse oximetry readings over a period of, I mean, few hours, less than 94, then you should be alerted. And this is we considered as a warning symptoms. So if pulse oximetry is showing persistent less than 94, then this patient should be hospitalized. Or if somebody is getting a persistent high grade fever spike, especially during the beginning of second week, this is very important. So the patients are getting fever in the first few days, then again become afebrile. And now with the beginning of second week, if somebody is getting very high grade fever, 100 to 103, I think this is the very important warning symptoms. We should be alerted, because this could be a beginning of hyperinflammatory phase or the cytokine storm. And that is giving you leukocytosis, high grade fever, lung damage, and hypoxemia. So high grade fever, especially in the second week, feeling of breathlessness, and the pulse oximetry showing less than 94, I think we should be alerted. And we generally advocate patients to be hospitalized when any of these symptoms is present during the home isolation. Apart from this, like we also recommend since last, with the availability of this evidence, that we also recommend inhalation budesonide. So Rotacap or the metadose inhalation. So budesonide has shown to reduces the rate of disease progression. So we also recommend budesonide, and control of diabetes. This is extremely important. So I think we should not discuss much about the control of diabetes, but this is very important. Next slide, please. So this is my last slide. So what are the important difficulties? So when we advocate the home isolation, the most important difficulties that we face is non-availability of proper isolation room at the home because of like poverty, the middle class people, this joint family. So 5-6 family members are living together in a small house. So the proper isolation room is not available. So we have to arrange, like government has arranged the hostels for such a family where the proper home isolation room is not available. The important difficulties that we are facing in India is fear. That I already introduced that fear not only amongst the patients but into the doctors also, and that leads to the over hospitalization or the over treatment of these patients. And another important difficulties in India that I would like to highlight would be there is a massive spread of misinformation by social medias. Like WhatsApp University is giving you so many misinformations about methylene blue inhalation and the drops of methylene blue. So there are so many alternative medications with very high claim. So, and the patients are also getting information from the friends, family members that, look, I mean, somebody has received this, and he has responded very nicely. So they will also start with all this, unscientific things for the treatment. And this can lead to, this invites more complications and maybe detrimental to the patient's health. And we have also very high claims from the quacks, alternative medicines that, look, we will give you a cure in your COVID infection. So these are the few important difficulties that we are facing in India for home isolation and home management. Thank you very much.
Thank you, Dr. Patel. Really, really useful and really helpful to understand the situation in India. Just to remind our viewers to ask questions in the Q&A chat function, in the Q&A box, and also that this webinar is being recorded and will be shared widely. May I now call upon Dr. Matt Inada-Kim with his presentation. Thank you.
Thank you. Do you mind advancing to the next slide? So really good to meet you all. My name is Matt. I'm an acute physician and I'm the national lead for COVID oximetry across this country and the clinical director for infection, deterioration and AMR. Our drive for this across England, and we're not telling you what to do because you know what to do. What we are telling you is about our experience in England. Was what we saw was a lot of cases of silent hypoxia of patients essentially presenting pretty moribund and severe, past the point of saving during first peak, blue, often without breathlessness. So we had to kind of rewrite the textbooks from that perspective with COVID, where we expected symptoms of breathlessness and profoundly, obviously unwell patients. We were discovering patients who had very low oxygen levels. And what that led to was a growth in awareness of this concept of silent hypoxia. And also, I guess, the value in what we put in the community and at home. Because I'm a hospitalist, I work in a hospital, but I'm the first to acknowledge the hospital is absolutely not where this battle is going to be won. This is about the community. This is about people in their own homes, in society, and about what they can do to both protect themselves and spot early deterioration. And secondly, what they can do to protect the health system from being overwhelmed with mild cases of COVID. So clear sound triage systems, aligned systems are the things that are going to make the biggest difference, not ventilators, not intensive care beds. This is about basics. This is about triage systems. Next slide, please. So what we felt very strongly about, in order to try and protect patients and the health system as a whole, we needed to focus on a few main areas. One, reducing needless and avoidable admissions, preserving the healthcare capacity for those who really needed it, and improving early discharge of recovering patients. Those were the two hallmarks of the flow element. To increase the flow element through the healthcare system was important. To slightly turn off the tap and to also ensure the exit of water from the sink was really, really important, and founded upon a partnership of trust between patients and society and politicians as a whole. We needed people to trust that they could get help when they became sick, when they triggered criteria. We needed to empower them with oximeters, knowledge, diaries, monitoring, and a safety net that worked. And that's why that patient partnership is so crucial to this and a pivotal element of the program going forward. Next slide, please. The evidence base for this was really important. So really early on, we did relatively large-scale studies to track the outcomes of patients with oxygen saturations at home, and then what eventually happened to them when they fell ill with COVID. And what we found was that 92% or less was the magic number in terms of when the steep increase in mortality rates happened at the 5-day mark and 30-day mark. And that's what we based our national guidance on. So if you hit 92% or below, you come in urgently if it's a persistent level. 93 to 94 is your amber band, which I'll go into in a minute. 95 to 100, you're pretty safe, particularly in the absence of severe symptoms. And we will share the links to these papers and guidances after the meeting. Next slide, please. In terms of the what here, this patient trust partnership is critical to this. The general public and society as a whole needs to understand the aims here very clearly. We need to be there as a healthcare system, and we felt very strongly for patients that were really sick. And patients needed to help us when they weren't sick, or we would be overwhelmed. And to that end, and to decide how we would go about this, we created this virtual ward strategy of keeping people at home with monitoring and safety netting. Translated into a multitude of different languages as guidance to teach people about what they should look out for, what normal recovery in COVID was and what abnormal was, when they should seek help. YouTubes to describe how to use an oximeter, when to be worried, and what the warning signs, the cardinal signs were. Translated diaries of resources as well, and then app formation across a whole different range of platforms, from anything that was incredibly low tech, actually just pen and paper, to phone and telemedicine and app-based digital solutions. Next slide, please. To back all that up, we needed clinical resources and quality improvement methodology to get the strategy across. And that involved developing elements of e-learning, simulation training, and app-based design to create dashboards for patients in their own homes so that we could do this at scale with minimal increases in staffing numbers. All of these are free resources and available, which you're all welcome to look at. The strategy, if I look back in a time machine, was very much about engaging leaders across systems from a variety of different backgrounds right at the beginning, developing that strategy and get colleagues on the same page across the whole country, and then establishing that at scale and backing it up with learning networks and forums to continue the conversation. And then this concept of sharing at scale. This was no one's property. This was about sharing for the common aim, and the aim to get alignment in the medium and long term, coupled with the early gains of what real data was going to show us at scale for our endeavors. Next slide, please. So our intervention went up pretty remarkably over time, and over a short period of days, and it was about 28 days in total, we managed to get up to the whole country implementing the same model of operating how we would do this pulse oximetry, with those three main aims being really key: early identification of deterioration, admission avoidance where possible, and early safe discharge to keep the flow going through the healthcare system. And my colleague's going to go into some of those QI tips and what we did from a strategy perspective in a minute, because it was a massive team effort across the whole country. That's how we got there. Next slide, please. The impact of this has been pretty remarkable. And so far, around 100,000 patients have been through this model across the country. And what it seems to have shown in areas where there is high uptake is a reduction in long length of stays, particularly 7 to 14 days plus in the cohorts since the implementation, and an increase in shorter length of stays reciprocally, showing that we're probably managing to keep the flow going through reducing unnecessary admissions. The mortality rate has dropped as well, and the model appears to be safe, with an overall mortality rate of less than 1% for patients put through this model, which is a far cry compared to our original 14.4% during first peak. And hospitals as good as the Royal Free and others amongst have demonstrated that by doing this model, you can keep admissions out safely by increasing your throughput through this virtual care model, something that can be applied to any condition. Next slide, please. So the excitement reigned about this, and to support this, we needed patients in harmony, in partnership. Clarity of guidance was really important, and the use of diaries and the like, with absolute clarity on what the criteria were when a patient should seek help around those oxygen saturations, what the symptoms of concern were, and how urgent the patients should seek help. So when you get to the hospital assessment, it becomes really binary. You're either coming in or you're going home. And then the question is whether you fall into the low risk or high risk category and what resources you have within your local system, because not everyone has an app or a computer-based system or indeed a smartphone. We had to do this within the confines of what a patient could do and what the system could deliver. And if all that we could do was give good advice, then that's what we did. Next slide, please. Dovetailing that was the clinical pathway, so that the same criteria were used up and down the country of what oxygen saturations were, how to use desaturation on exertion tests, and what the symptoms of concern were, what tests were necessary to ensure that we had some degree of alignment. We were going to live or die by the standardization and alignment across all our systems, including ambulance and community as well as hospitals. And what we found from this model was that it could be set up really quickly. And I've got a wonderful colleague, Bushra Alam, is going to talk about that in a minute. In terms of the COVID virtual ward methodology, it was based around more intensive follow-up of patients, but patients did well as well with a lower acuity model and a lower light touch model in resource poor environments. There's no perfect model. There is no one size fits all here. Next slide, please. So the WHO, in conclusion, have now supported this model internationally, which is good to see. And we continue to broadcast what we feel our saturation guidance should be and when patients should seek help. A key element is that trust element between the general public and society as a whole, with these aligned principles of protection, both for patients' own health, but also preservation of the healthcare system as a whole. Because if we do not achieve that together, then we are sunk as a healthcare system. I'd be very happy to help in the future with any other questions and look forward to seeing how India develops, because what an amazing country. And I think within a few weeks, the UK and other countries will be looking to India for the answers as to how it should be best manage COVID. Thank you.
Thank you, Matt. Really, really helpful. And now, may I bring in Dr. Kathy Smith to talk about the COVID assessment and CCAS experience.
Great, thank you. Firstly, CCAS was the COVID Clinical Assessment Service. I'm a GP and I also work for the service as an auditor, so involved in the reviewing of a lot of these consultations. The CCAS, as we call it, was comprised of GPs and allied health professionals. And these were GPs who returned to practice and also retired GPs. So we were harnessing sort of the available doctors to us. In terms of access to the service, anyone with a telephone could access our service, CCAS, by calling 111. And once they call 111, they'd get filtered into CCAS if they were had confirmed COVID illness or had suspected COVID symptoms. And I'll just share with you what we, next slide, please. So we had to draw a line in the sand, and if you had fever symptoms, so importantly, not a numerical value, not a temperature threshold, any symptoms of fever, cough, breathlessness, or change in your sense of smell or taste, you'd be filtered into our work stream. Next slide, please. So this is the sort of model. At the top, you have your cohort of patients with symptoms of COVID. And it's important that at the top in that black box there, that's the first layer of triage, and that's critical. Because if it's an emergency and they need urgent hospital assessment, then they go off and stream off into cohort 1. And if you're unsure and they need further clinical assessment, then they come into cohort 2, that blue box, and that's with us at the COVID Clinical Assessment Service, CCAS. And then cohort 3 were the patients with mild symptoms who are safe to stay at home with self-care advice. And it's important that this is a fluid model, so once you came through cohort 2, the CCAS service, you could be reassigned to cohort 1 if you felt that actually this was a really unwell person with serious symptoms, or then reassign them to cohort 3. And once they're in cohort 3, there's that mechanism for them to go back through that triage and assessment service 24 hours a day. Next slide, please. So within cohort 2, we also had patients with mild symptoms who were identified as having risk factors for poor outcomes. And for ease, I've just condensed some of these risk factors here. Next slide, please. So in terms of remote COVID assessment, just in terms of the skill of it, it's a real upskill, COVID remote assessment. We went back to basics. At the start of the pandemic, we didn't really know what to expect apart from an atypical pneumonia. And so we all, as a cohort, just went back to sort of, full history taking, a good systematic inquiry, making it brief, but making sure you cover, and as Dr. Patel mentioned earlier, hydration and assessing that, build a picture in your head of how unwell that patient is whilst on the phone to them. And I've put red flags, and red flags are really important, but there's more nuance to this. What we were seeing were the sort of clusters of symptoms coming together, and as Matt alluded to earlier, the patients who were not breathless but were hypoxic. And collateral history. When you're assessing remotely, use what's available to you. With consent, ask if there's a family member, just so that they can be your eyes on the ground. Next slide, please. So then you go on to your assessment after you've taken your history. And like I said, use your adjuncts, video, if that's available to you. So we had that facility. And home monitoring equipment. It's amazing how many people might have an oximeter or a blood pressure monitor at home lying around. So just ask them to get it out, put it on, and use that video to help direct them if needed. And I've put breathlessness here because really, breathlessness is a real critical line of inquiry. Really ask about it and really assess, the trajectory and the onset, whether it's sudden or gradual. That's really going to help us when we're assessing remotely. And target your information gathering. That's really key. Next slide, please. So once you've finished your assessment, you want to come to your management plan. And it's really difficult when you're on the phone remotely to feel confident in your differentials. But use that history and take your time with it to help hone your differentials. Think about non-COVID and COVID pathology and the fact that it might exist alongside each other. Our bodies going into this pandemic are the same. So if you had risk factors for stroke, heart attack, those risk factors still exist. Let's not miss these. And it's really important that we don't delay care to those who need it. And with differentials, think about the seasonal variation. So for us at the moment, we're thinking about, we can see a sort of COVID and hay fever crossover, but tease out the information. So do they normally have a cough with hay fever? No. So then, really use that opportunity to advocate testing and isolation. Prescriptions. I've put that there because actually I would really say, think before you prescribe. Does this person need a prescription, or is this going to delay an assessment for them? Next slide, please. And in terms of management, first off, you're thinking, do they need to be seen? I.e., do they need acute assessment today? Or do they need to be set up with an oximeter so that they can monitor their symptoms? And actually, then the next question is, are they safe to stay at home? And so with this, I really want to highlight that, safeguarding issues. So are there other reasons why they need to be referred in to be seen? Is there something on the phone when you're listening to them that just doesn't sit right? And that's your gut instinct as a clinician. Think about domestic violence, think about vulnerable patients and safeguard them. And then, do they want to stay at home? And we heard this, throughout the year. So actually, people who just did not want to go into hospital. And so we've got to respect patients' wishes. And in doing so, we've got to think about capacity assessments, and don't try to make that decision on your own. Use, call on help. So actually, for us, if you're struggling to come to that conclusion, refer them on to a colleague. Maybe it's better that a doctor goes out to them at home and has that discussion with them. And so, thinking about palliation for those who absolutely are really poorly but want to stay at home. These are challenging consultations. They're not all straightforward. And safety netting, worsening advice, and fail safe advice for us. So actually working remotely, making sure that if your referral or the advice you gave to the patient doesn't happen for some reason, what do? Let them know. And that empowers patients, because it empowers them to know that, okay, I'm okay to call 999. I'm okay to call for an ambulance. Next slide, please. And so I'm just going to, next slide, please. Top tips: speak to the patient first, play to your strengths as a clinician, and think about your well-being. Think about, are you too tired? Each time you tell someone they've got suspected COVID, it's breaking bad news. So make sure you're mentally prepared for that. And public health messaging, make sure that your advice aligns with local guidance, and take the time, use that golden minute at the beginning of the consultation to build rapport, because that fosters trust and that helps with our wider messaging. And then if I just go to the next one. Keep up to date, align with local policy and guidance as before, and make sure your differentials are situation specific. So you'll have different ones wherever you are in the world. Next slide, please. And lastly, take pride. This is a really hard job, and be proud of the work you're doing. I've thoroughly enjoyed working with CCAS for the past year. It's been a real privilege. And in terms of governance, it's been at pace, set up under the steer of Enid Povey, our clinical assurance director, and Jean Challoner, Sarah Kay, and Caroline Warren, our medical leads. It's been just such a steep learning curve for us all. And then last slide. Thank you very much for listening. It's such a rich experience, and I'm really hopeful that our lessons learned can be of help to you or wider professionals.
Thank you, Dr. Smith. Really, really helpful. Can I just ask one question while you're on that? Could you just clarify for participants what you mean by a red flag?
Yeah, so red flags, there's a whole complex list of red flags actually by system inquiry, but specifically for COVID, it's asking about things like chest pain, making sure you're not missing that, because they might not volunteer that. And red flags in terms of not only identifying their risk factors, that list I put up earlier, but also things like difficulty breathing. If this person is struggling to actually complete the sentence with you, don't continue with that history. You need to get them seen early. Other things are dehydration and myalgia. We really saw that myalgia was a really significant symptom featuring in some patients. And so they might not be breathless at all, but with that profound myalgia, struggling to get out of bed, that's really important to pick up early, and the impact on their activities of daily living. That's really important to get across. Like I say, build that picture of how unwell this person is from their baseline. Brilliant, thank you. And we can share the list of red flag symptoms with colleagues on our website as well, which we'll do after this. Great, thank you so much. Now, may I call upon Dr. Bushra Alam to talk about COVID oximetry at home and virtual wards. Thank you.
Oh, hello. Thank you. Thanks very much, Harpreet. So my name is Bushra Alam, and I'm a consultant in acute medicine, but also working with the oximetry at home team. And I thought very briefly I'll share some of our experience in setting up COVID virtual wards in Salford. So last October, we were under quite a lot of pressure. We had a high number of COVID cases and our hospitals were full. The A&E department had no capacity to be able to send patients to the ward because it was full of both COVID patients and non-COVID patients. So very quickly, we had to set up a system of where we could discharge patients safely back into the community. So what we did have at the time was pulse oximeters, and within an hour, we set up a very simple but safe approach to managing patients. And this was our basic model where we had our pulse oximeter, we got the diary and some safety netting advice for the patients of what to do if their saturations dropped. And we also had a 24-hour telephone number for patients if their saturations dropped or they felt more breathless. And what we basically said to our patients was, this is how you measure your oxygen levels using a pulse oximeter. And if your saturations are above 95 and you feel well, then continue monitoring your saturation levels at home 4 times a day. And if your saturations drop to 93 or 94, ring that number, which was a 24-hour telephone number where they could ring for advice on what to do next. And if your saturations fell below 92, then you need to get yourself into hospital within an hour so that we can start treatment and oxygen. So that was our very simple, basic approach. And we use that for our patients to increase the safety of what we were doing, but also to be able to discharge our patients home. And that approach worked really well. We had a number of patients that rang up that number when they were uncertain, when they felt breathless, or their oxygen levels dropped. And indeed, we had a number of patients who self-presented to A&E when their saturations were below 92. So that was our initial approach, and that was to add safety to our system. What we then did is that we built up on that, and we managed to get the staff in who were then able to ring the patients. And these staff rung the patients every other day to check that they were using their pulse oximeter well, and that they were being able to check their saturation readings and be able to act on it. On a number of occasions, us ringing the patient really worked. In one case, there was a carer who was writing down the saturations for the patient. And irrespective of the fact that the saturations for the day were about 88, the carer did not escalate the patient to secondary care. So it was really helpful when our team rung the carer to find out what the patient's saturations were. And also there was one patient who was characteristic of silent hypoxia. He had very low saturations. His saturations were 83, and he felt well. He didn't feel breathless and therefore didn't want to come into hospital. And luckily our call handlers were able to convince him to come into hospital. Following on from that method, we've got even better. And this is where we've then introduced, with time, technology. We've got apps where patients are able to upload their own readings onto an app, and our staff are able to monitor a virtual dashboard and see what their oxygen levels are. And if there's any concern and patient records an oxygen level that's low, we're then able to ring that patient and check on their well-being. But our system, rather like yourself, we were overwhelmed. We had a number of patients that were in our A&E department. We had no capacity in our hospital, and we had to start somewhere. So we started with our basic model and then developed it further. What we were then able to do when we were under more pressure with the Kent variant back in December this year is that some of our hospitals were able to use oxygen, and they were able to have a selected cohort of patients who were doing well in hospital, who had an improving trajectory, who were stable on oxygen for about 48 hours and had a very low oxygen requirement of less than 4 litres. We were able to send these patients home with oximetry, with very comprehensive, detailed monitoring, home with oxygen. And we were able to do that fairly safely. And we had to do that because we ran out of capacity at one point in some of our hospitals. So it is possible to have patients home on oxygen, but they have to be carefully selected patients and patients that are improving and that are taking perhaps a little bit longer to wean, but with the right safety netting and the right follow-up in place to make sure that they're doing well. Thank you, Harpreet. I'll finish there.
Thank you, Bushra. Really helpful and very insightful on the model that you've developed. And then finally, may I bring in Cheryl to give us an overview of the Academic Health Science Network and the rollout of the oximetry program. Cheryl.
Thank you. Thank you to all our previous speakers, and welcome to everybody. It's a pleasure to talk to you. What you've heard so far from our clinicians is the importance of setting up these new pathways of care, how we enable these pathways of care to be set up at pace, and the criteria that we were able to admit patients onto these pathways. What I want to talk to you about in this last slide is the support that we've been giving to our frontline clinicians to enable them to do this at pace and scale. And as Matt showed you in a previous slide, we were able to set up these pathways in less than 28 days, and in some cases, less than a day in some parts of the country. So we've been building on the existing work that the academic health science networks have been able to do and to support our frontline clinicians. So as the patient safety director for the academic health science network, we were enabled to mobilise our workforce to support them. The academic health science networks are a group of 15 regionally based centres, part of the NHS, that have within them patient safety specialists who are improvement specialists who can help our frontline clinicians. And we did this in a number of ways. So we built on the existing work through our deterioration pathways, and part of that was developing a national learning network. We ran this very frequently, every 2 weeks at the beginning, and we invited participants from across our hospitals and our primary care systems and community services to come and share their experiences, to share their knowledge and exchange learning and resources, ideas and innovations, so that others could learn quickly and take on those innovations at pace. They also had an opportunity to make contacts, ask questions and offer support. And all the resources that were developed were put onto our platform, a web-based platform which we call NHS Futures. And all our healthcare staff are able to access that platform to download the resources so that they don't have to start from scratch, and to also add resources that they've developed for others to share. And we also set up a number of patient safety networks. These were already in existence and we usually would meet face to face. But on this occasion, we went virtual, and we encouraged people to come to these networks to share all the learning and opportunities to talk to each other in a way that felt safe and enabled people to work at pace. So I think what I would like to finish on is to say thank you to everybody who supported us in the most collaborative way through all the systems we had in place. Thank you.
Thank you, Cheryl. Really helpful. Thank you. And now, if I may hand over to Alison to lead us through the Q&A for the next 10 minutes. Thank you.
Thanks very much, Harpreet. And I just wanted to say, before I start answering some of the questions, to clarify that a number of questions have been on vaccines, which we're really sorry, but we're not able to answer those today, but we will hopefully have a future webinar on that. And then one of the other issues, we've also been asked a number of clinical questions about individual patients. And while we'd love to be able to do that, we're really sorry that we can't answer about individual people as part of this. So my apologies for those. But there are lots of different questions. And one of the ones was actually, this is for Matt and Ada Kim, what are the outcomes for comparing people being managed on normal wards compared to being managed on the virtual ward? I think you mentioned it, but could you perhaps highlight that for us, Matt?
Yeah, sure. Do you mean being admitted to hospital, or do you mean COVID virtual wards versus hospital-driven versus primary care-driven COVID oximetry at home?
Yes, that was the question. Yes, please, if you could.
So a GP-led or community-led model versus the hospital-led model?
Yes.
Okay, so with the two versions were essentially across our country, a primary care step-up model, which involved keeping people at home and obviously not going to hospital unless really, really necessary, with the safety netting happening from general practice in the community. And this was by far the largest group of patients. And there are good examples of very low admission rates, less than 8% from patients onboarded and monitored using pulse oximetry in these areas, and very low mortality rates, on average less than 1%. The hospital model, interestingly, had similar mortality rates overall, over similar numbers when studied, although had a higher acuity of patient, because obviously these are patients who had either presented to the hospital with a syndrome of COVID, or an ambulance service, or had been rapidly discharged from an emergency admission. The mortality, again, for that group was around the 1 to 1.1% mark. So not clinically that significantly different from the primary care model. Both of them were associated with very low mortality rates, and far lower than what we had been seeing with COVID up to that point.
Thanks, Matt. That's very helpful. Dr. Patel, on that, I know that we've heard there are quite a lot of COVID models being delivered in India. We've heard about it, perhaps Andhra Pradesh, Hyderabad. Are you able to share any more information about what models are actually being used already in India? We've been very impressed with some of the numbers we've heard already today.
So I mean, I know detail about the home care model that we provide in Gujarat state. So I cannot comment on Andhra Pradesh or the Punjab or any other state. But what we do in Gujarat, that the most of the college hostels, they are vacated, because I mean there are no the online, I mean not online, but there are no colleges and schools, so all the hostels are vacant. So what we do, like all the university hostels are converted into a isolation area. So for those families where they do not have adequate home isolation facility, so we keep all these infected COVID-19 patients with the mild symptoms, we keep them into the hostels, the boys and the girls hostels, and we put the medical officers there in charge of that particular hostel campus, and he will look after the most of the patient's symptoms. And of course, they do have access to the corporation helpline as well as the government helpline. So whenever they feel any problems like hypoxia, the oxygen saturation is going down below 94, they can call up the corporation helpline or the government helpline, and they'll be shifted to the hospital care facility. So this is number one. The second facility, the facility that we are providing for a home isolation is that, so for those patients who has the adequate home isolation facility, so we have kept all the final MBBS students from the 7 medical colleges that we have in Ahmedabad. So daily, like all the MBBS students, they gather into the medical colleges with the taxis hired by the government of Gujarat as well as the corporation. And 2 medical students are, along with 1 nursing staff, they occupy 1 taxi, and they visit one particular area to get a follow-up of all the patients, those who are kept in home isolation. So entire Ahmedabad is covered by the final MBBS students along with the nursing staff. So they carry all the primary medicines like paracetamol, some the electrolyte solutions for hydrations, and some antiemetics, or all the first aid needs. So they will examine the patient, they will record the temperature, they will record the pulse oximetry, and they will report to the central officers. So whenever they found that this patient is not doing well, patient is sick, so immediately the patient will be transferred. So daily, like the medical students, they are, going to the patient's home to examine them, to evaluate them, and they will provide the adequate services. So we have the hostel isolations, and we do have home isolation with the care being given by the medical students.
Thank you very much, Dr. Patel, and thank you also for mentioning the government helpline, because I noticed one of the other questions was actually where people should call if they had low oxygen levels. And a number of questions have been actually, how should we be treating patients in the community, particularly if they've got mild COVID, how they should be investigated and also what treatments. And I was wondering, Tara, is that something that you could answer? What type of treatments you'd recommend for mild COVID?
Yeah, so what we recommended for a mild COVID, like when the patients are opting for home isolation, we ask them to have a good hydration. And if we found that patient is having a very high risk of disease progressions, like some comorbidities, poor NLR, patient is having raised inflammatory markers, so I add inhalation budesonides along with the paracetamol and the supportive care. And we monitor them very frequently and closely. And especially when somebody is having a diabetes, because with the COVID, like we have noticed that their sugar control is haywire. So we ask them to monitor their sugar at home and to take control of this sugar. But when patients entered into the second week and patient is not having the proper control of the symptoms and getting a new onset fever, so we again repeat all the investigation. If we found that there is progressive inflammations and patients having worsening of the respiratory complaints, then we ask them for a hospitalization. So most of the patients with the mild symptoms, we just give them paracetamol, rest, hydrations, and explaining the prone positioning, that's it. But budesonide of late we have started using for a patient who has a very high risk of disease progressions.
Thank you very much. And Tara, are you able to add a little bit, because there's been some questions about what other blood tests and CT scans and chest x-rays, what the place is of that for people with mild disease? You're on mute, Tara, sorry.
Yeah.
Sorry, Tara.
Yeah. For patients being managed at home, really they won't need any additional investigations such as high-res CT, chest x-ray, bloods, etc. But when patients came to the emergency department in the UK, we would have done a panel of bloods which would have included a CRP, a D-dimer and a chest x-ray, and depending on that we would have made a decision along with their saturations and then used two regarding whether they would be suitable for management on the virtual ward or whether they required admission. We didn't use CT scanning as widely in the UK as it has been used elsewhere in the world, including India. And we found that chest x-ray was a useful enough diagnostic test for initial management of COVID. But obviously, if you've got a high suspicion that someone has another pathology going on, or you've got someone that's very seriously unwell, or you're suspecting COVID and they've got a negative PCR, then that would be a reason to do a high-res CT. In addition to that, if you're suspecting that there's some sort of degree of pulmonary thrombosis, then that would help. So those are the kind of tests that we would be doing in the hospital, but really in the community you can check their oxygen sats, their temperature, their pulse, and their respiratory rate. I think those would be the sort of key things to look at.
Thanks very much, Tara. And there have been questions about D-dimers, but I think we're probably good because time's short. We'll have to move on. Thank you. Harpreet, I know we were hoping that we might, because there are lots of questions, whether we might be able to extend it by another 5 or 10 minutes. Shall we continue to do that because we've got so many questions?
Absolutely. Yes, that's absolutely fine. Thank you.
Because one of the questions I had was for Sonali, was a lot of people are about asking in the UK, what support can we actually provide? What's being done in the UK and how can people link in both ways?
Yeah, thanks for that, Alison. So there are a few ways. I can see that a lot of people were asking some personal questions in terms of the conditions or what's happening with their family members or other patients. So there's a project Step 1, which doctors in the UK may wish to log on to if they wish to provide remote service. Do check in with your indemnity organization. We are gaining clarification through the General Medical Council as well. There are also multiple informal groups that have been set up where we're trying to provide peer-to-peer support as far as we can. And also I know that some case-based discussion, kind of anonymized case-based discussion that is taking place. Also look out for an organization called as BAPIO, who are also trying to organize, again, clinician-to-clinician support and telelink, where they will be able to advise on case-by-case basis.
Thank you, Sonali. And I know we're slightly running out of time, but Matt, I was wondering if you could just clarify some of the at-risk groups. We've had a number of questions about pregnant women, and I know that's something that we've discussed in great detail. Could you perhaps give a little bit of clarity on the at-risk groups and also pregnant women?
Yeah, well, so we haven't actually noticed a massive increased risk with pregnancy generally, because obviously most are young and female for a start, who are lower risk than males anyway, and are usually fit. So as a result, only pregnant women who have associated with severe comorbidities and particularly cardiovascular diseases are part of our clinically extremely vulnerable list and qualify for COVID oximetry, not pregnant women per se. The other groups are age determined, as people have found in India. Our initial criteria were 65 or above, or under 65 with serious underlying illnesses, plus clinical judgment. So we allowed the flexibility of our clinicians to decide if they were really concerned about a patient to put them on that intense monitoring as required. And what we found since the widespread vaccination across England is there's been a 93% reduction in cases in those vaccinated, so particularly in the 65-year-old plus groups, meaning we have further dropped the level of inclusion criteria for who gets onboarded to COVID oximetry at home, as the majority of our emergency admissions now are happening in under 50-year-olds and our intensive care admissions as well. So the success of the vaccine breeds a different cohort of patient and an alteration of the entry criteria, meaning you have to be dynamic and flexible with how you approach this condition.
Thanks, that's really helpful, Matt. Harpreet, perhaps I could pass back to you. I think we've got some more questions, but I was wondering whether we might be able to collate some of the questions and provide a question and answer, a fact sheet at the end, because as some people have seen, some of our colleagues have been sharing some of the results from the UK, and if that would help, we could certainly help collate that together. Shall I pass it to you?
Yes. No, thank you, Alison, and we will absolutely do that. So thank you for all the questions that have come in. We will certainly collate them, capture them, and get them answered by experts, but also provide the relevant resources that have been mentioned throughout the webinar. Well, firstly, I would like to extend a extremely thank you to colleagues who have provided their time and insights and experiences, both from India and the UK, in terms of what is happening and how to best manage the current situation in India and beyond, where we are experiencing second waves of the pandemic. So first, thank you very much for that. I just wanted to remind everyone that we will be disseminating the recording through a link, and the delegates will receive the link of the recording, and it will also be both on the AHSN Network and the South Asian Health Foundation YouTube channels, and we will ensure that that gets disseminated and sent to you all. Additionally, we will be making infographics on today's topics, and I think if we can share those as well, then you'll have that ability to share those with everyone. If you were wanting to learn about a certain topic, then please do get in touch, and we can organize a webinar and hopefully work out how best we can do that for you all. And so just on the final remark, if I can just go around each panel member just to give one kind of passing advice to everyone on the call, that would be great. So if I start with Matt, please.
Just that you can do it. I think the ways forward. Don't give up. Learn from our mistakes in England. And England does not have all the answers. We're looking to India to innovate and look at the better version too going forward. And that partnership with community and society as a whole is so critical to protect both patients, but also a very fragile health service. So getting that right is really important. And I'll be really interested in both helping, but also observing what you do from here on in.
Thank you, Matt. And then if I may go to Bushra.
Thanks, Harpreet. So I think this model is really very much about empowering the patient, empowering the clinician, starting treatment at a point when the patient deteriorates, and freeing up hospital capacity to be able to discharge patients and enable them to go home safely. So maybe not one sentence, but a couple of sentences there, but definitely I think it's worth doing.
Thank you. Katie, Dr. Smith.
Yeah, I would just say that, you know, keeping it in the community, and really it's critical that we keep patients who can be at home and empower them and reassure them, and also making sure that we spot those sick patients early, using decision support, using sharing learning, and once we spot them early, you know, prioritize their assessment. I think that's where we need to really, you know, roll out this.
Brilliant. Thank you. Dr. Patel, if you're still there.
So I think I would like to say that, I mean, for patients that do not demand unnecessary pharmacological intervention, and for doctors also, do not do any unnecessary pharmacological intervention to all COVID patients. Let them recover spontaneously, because unnecessary pharmacological intervention can give you some side effects, especially when you are using steroids. It will increases the replication time, it will produces more shedding of the virus into the environment, can lead to the more infections and give you a more complications to your patient. So please avoid unnecessary pharmacological intervention. Let patients recover spontaneously. Just monitor very closely for a high-risk patient and do specific interventions whenever the patient needs it.
Thank you. Tara, Dr. Sood.
Just like to say, be kind to each other, look after each other. You're working in very, very challenging circumstances and it's exhausting. And not everyone has as much as resilience as everyone else. And also everyone finds it challenging at different times in the journey. So just look after each other and we are with you and we are sending you our very, very best.
Thank you. Dr. Cheryl Crocker.
Thank you. I would say collaborate and use your support networks as best you can to help you.
Thank you very much. Dr. Sonali Kinra.
Yeah, just reiterating this message that we are all here with you in solidarity. I know you're all carrying a massive, emotional and mental burden, and we have been there. So please reach out for support. There are multiple groups that are around that we'll be happy to support and give as much support as we can. But this is not just your own burden to carry along.
Thank you. And Dr. Allison.
Thank you. I was just going to say keep learning, because I've already learned today Dr. Patel talking about using medical students, and it made me think about doing something differently, because that was the value of the learning network that Cheryl set up with others, that we just shared ideas and it helped us moving forward. So hopefully we've given you some ideas today, but you've also given us some ideas as well. So thank you very much for the sharing.
Brilliant. Thank you all. And just to echo that, if I can get this final slide up, please, on the Friday webinar. So, we said this is one of many webinars that we've organized. And so we have a series. And then we have the second webinar on Friday, the 7th of May at the same time, 4 p.m. UK time and 8:30 India time, which will be on hospital and ICU management of COVID-19. And again, we have an esteemed group of individuals, both from the UK and India, led by Dr. Nikhil Tandon from AIMS, who will be sharing information on hospital therapies, glycemic management, ICU management, and anticoagulation therapy. So thank you again. Just to reiterate, the channels are open. Please keep in touch, and we look forward to seeing many of you on Friday. Thank you.